Don't forget to hit the record button before you start.
Yep, just did. Thanks, Chief. Let's go. All right, Capo. Maybe I'll, when I'm playing videos, maybe I'll keep this mic near the speaker just so you guys can hear better. Let me know if you guys are having trouble at home. So, hey guys, my name is Josh Miller again. This is my third class I've been teaching you guys. So, hopefully things are going well. We've got just a few guys in the house today, but hopefully everything's going good so far with the class. I think you guys have just how many more weeks left? Not much, right?
We're over halfway.
Yeah, over halfway. So just to start things off, we're going to be going over soft tissue injuries today. So just start thinking about different mechanisms. We'll start with a video, how there's tons of different ways to cure soft injuries. So just a couple minutes of this and get you guys' brains woken up this morning. So think about how you classify these injuries. Oh. All right, we can get back to that video throughout the class just for educational purposes, but we'll move on. All right, so just looking through this slideshow, soft tissue injuries. I mean, it's kind of the really cool to look at, right? It's really cool to treat. All different injuries are kind of very distracting injuries, but in all reality, for us out in the field, it's not that complicated to treat. Usually, if it looks bad, let's just cover it up and put pressure on it 90% of the time. So, going through the slides. To be honest with you guys, I don't really like a whole lot of the slides. It kind of is redundant, kind of states a lot of the obvious. So a lot of it I'd like to just kind of talk to you guys about, get some feedback. We'll get through, and then we'll just kind of only stop on the slides that I think are pertinent, but not if you're someone that really likes to read every little spot on the slides, then absolutely I encourage you guys to go back. I know you guys have access to those. So So let's start off with the anatomy of, let's just talk about anatomy of the skin. So what are the layers of the skin? Yep, epidermis, dermis, and yeah, subcutaneous, or also called hypodermis, right? And what is let's start with the top one, epidermis. What does epidermis contain? Right? It's yeah, see chief. So it's pretty much just a bunch of dead skin cells getting pushed out by the new skin cells. Ryan, you remember what skin cells are called in science class? I think you were telling me the other day it was like simple squamous epithelial, right? Yeah, that's what it is, right? Just remember, you might see it in a test question, like epithelial cells. Think they're also skin cells. Okay, there's tons of different names for the kind of cell, whether it's multiple layered, like stratified means multiple, simple means one layer. You got squamous, cuboidal. Probably a couple other ones out there, but so depending on where it's located in the body, you're gonna have those different type of cells. But so what's the next layer? Dermis. What's in the dermis? Hair follicles. What else? Nerves. Yep. Yep. Sweat glands. Sebaceous glands. What's sebaceous glands?
It's like
Oil. Yeah. So, and what does that oil do for us? Yeah, waterproof. And one more thing it does. Yeah, it keeps it pliable, right? So we're able to stretch, we're able to flex, we're not just sitting here super tight, barely able to move. That oil is called sebum, so it's just a fatty oil. So makes your skin watertight and pliable. Very common question I've seen, so be prepared for that. Blood vessels, nerves, hair follicles. And what's the third layer again? Subcutaneous or hypodermis. And basically, what is that layer?
fatty layer.
Yep, fatty layer, which does what for us?
Insulates.
So here's a few types of wounds out there. What you guys just start naming them out. When you guys think of wounds, what kind of wounds are there out there? Yeah, open. So what does open mean? Um, Not yes. So a bone through a skin would be considered open, or anything that breaks the skin is open, right? And then so obviously closed, mean not breaking the skin. With closed, you still have to be worried about like hypovolemia. You can have a closed injury to this, like the thigh, and before you even start noticing swelling in a thigh, there can be a liter of blood in that compartment. So closed can be just as severe as open. All right, so avulsions. What are avulsions? Yep. Yeah, flap of the skin. There is some good pictures in this slide, so we'll get to that. Bite wounds. So human bite wounds, very serious, just because nasty mouths, highly probable for infection. Any other type of wounds you guys can think of? Yeah, burns. What kind of category of burns, excuse me, are there?
Partial thickness, full thickness.
Partial. So what's partial? So
There's that superficial, partial, and full.
yeah, so let's start with the top layer, superficial, right? So that's just that top layer of skin, right? You'll see, what's that?
Like a sunburn.
Like a sunburn, right? And then what's a second degree burn also called? Partial thickness. And what are we looking at there?
Blister. But yeah, blisters.
Yep, blisters. Maybe a little bit a white sometimes, starting to get deeper into that second layer of skin. And then last layer of burn is what? Full thickness, third degree. And how does that present?
Charred and black and killed all the nerves and skin and all the way through to the muscle.
Yep, so charred, black, all the way down to the muscle. So has anyone in here or out there seen third degree burn? Okay. I think I've only seen it once. It was right in the center of the chest. Guy welding on a tanker. There blew up. And there's an explosion and kind of just seared his airways and a third degree right here in the center of his chest. So you guys all know this already. They talk about you'll never just have 1 degree of burn if you have a third degree, right? The outer area is probably going to second and then first. So the third degree doesn't. It's already burned through the nerve ending, so you're getting down to the second degree. On the outer side is where it's going to hurt. So kind of just covering a general topic of wounds and burns and stuff. When we kind of get to that stuff, it'll just kind of be a review. Since we are talking about burns, electrical. What do you guys know about like entry wound and exit wounds of electrical? Okay. Has anyone seen an electrical burn? No? Okay. Definitely another good one to watch videos of. It's very, very scary for sure. So the exit wound of electrical, so wherever you touch and wherever the electricity decides to leave the body, at least resistance, can have devastating impact. It can blow off limbs. Usually you might just see a very small burn mark. Someone grabs it with their hand. You might see very little burn marks on the hand, but say if it goes out your knee, it can look like someone took a shotgun to it. So just depending on the amperage. So chemical burns. So like as a kid, I remember going fishing on a little aluminum boat, but all winter long a battery was sitting on that seat and the battery acid was all over that seat. I was wearing shorts and I sat down on that seat and went fishing with my grandpa. And then after a few hours, I'm sitting there just feeling like my butt's on fire. And finally, when we got out, I didn't want to say anything, but when we got out, my shorts and underwear was totally eaten away and shredded. And my ass had chemical burns, So don't worry, nothing, no long lasting effects. It's good now. But yeah, so you got to be careful with chemical burns. Is the chemical water reactive? So trying to figure that out before you just get into treatment. Do you just flush with water or do you do a dry decon? So getting those like NIOSH books out or contacting. What's the number we contact for hazmat? What's that? Poison control might be able to, but yes, on the electrical burns, several. Oh, okay. Yeah. So thermal. So that's our fire, our deep, our burns, our superficial, partial thickness, and full thickness. So, if anyone texts you in class, we love to just share it amongst the class. I'm sure. Is that Kaipo, Rusty? Okay. Oh. And then radiation. What kind of radiation is there out there? Hazmat. Yeah, hazmat tech, right, Rusty?
Hazmat?
Yeah.
Have you dealt with any chemical burns at all, or?
Have I dealt with any chemical burns? Nothing right off the top of my head that I can think of. I'm sorry. Gosh, I've had to have come across a couple things here and there. Yeah, I'm sorry. I can't think of anything off the top of my head. Has anyone else that you guys can think of? No. Same thing with battery. Yeah. Now that I think about it, I have been. It's not. It's more of a pesticide, so it is a chemical. But I have come across people that's been around pesticides and have started that, getting sick and vomiting and lacrimination from the eyes, and yeah. So organophosphates, good one. Crush syndrome. What's crush syndrome? Yeah.
Pressure on something and the tissue breaks down and it can break down into your bloodstream.
Yeah. Remind me, what was your first name?
Max.
Max?
Yeah.
Yeah, so Max, you have it correct. So when there's an impact on a body part for an extended period of time. So in this field, a lot of times on any kind of structural collapse onto a body, or car accidents where we have vehicles with appendages being crushed, or any part of the body really. Typically 4 to 6 hours is when you start seeing crush syndrome. So when that body part is being crushed, there's a lack of blood flow. So we know blood flow is bringing in oxygen and nutrients, and then it's also taking the bad stuff out, right? So when that crush injury is happening, we don't have that blood supply, and then those cells in that affected area go from an aerobic metabolism state to an anaerobic. So no oxygen, right? When your cells go into that anaerobic metabolism, we're now looking at a lot more release of what, do you think? What's that? Lactic acid. Okay, so that lactic acid changes pH, right? So very hard on the body, as well as those cells, down to back to that cellular level. Okay, those cells, the cell wall is no longer containing its contents. So within that cell, now you have that potassium being released. We know potassium is going to do what? Any idea? Trigger cardiac events, right? So cardiac dysrhythmias, okay? Because we remember that sodium potassium pump a little bit, and it's a big deal for our heart and muscles to contract. So that extra release of potassium is going to cause cardiac dysrhythmias. So it also is going to release myoglobin. What's myoglobin? Just muscle cell, myo. So that is going to be very hard on our kidneys because it's a larger substance. So it kind of clogs up the filtration system of the kidneys, is the way I like to look at it. So we're going to be starting to look at renal failure. So the release of potassium, myoglobin, and then all the extra contents of the cell can start affecting other body organs such as your liver. Okay. Let's see here. So overall, what does your skin do for you? Right, Max. So the skin is going to protect us from the environment, right? So disease, any kind of forced from the environment, that causes the traumatic effect. What else? Regulates temperature. Yep. It holds all of our nerves, right? So without our skin, to be there, it's going to tell us what's hot, what's pain, what's cold, what's warm. It holds a bunch of fluid volume, so it's able to shift and compensate for our body. So dressings and bandages, we already know this, but we're going to use them to control a lot of our soft tissue injuries, prevent further contamination, and protect the wound from further damage. Blunt injury, energy exchange between the patient and the object is more than the tissues can tolerate. Penetrating injuries, objects break through the skin and enters the body. So do we want to remove penetrating injuries? The foreign object? No, not usually. So what circumstances would we? Interferes with CPR and airway. So another very common test question. When it comes to penetrating injury in foreign objects, unless it's going to hinder your CPR or is in the airway of in the way of an airway. So burns, we're going to get more into that a little bit later. So we already talked about the skin in depth as far as this slide talks about 2 principal layers. I would know all 3. Know your hypodermis or your subcutaneous being your fat layer that regulates your body heat. Here's a little bit of a picture of that epidermis, dermis, and subcutaneous tissue. Just you guys already have a good understanding of what all the terms that you might see in the dermis, but just be familiar with erector pili. I'm sure I butchered that muscle, but that erects the hair follicle. Can't talk this morning. I apologize. So skin tension lines. This is not something that I was very common with before the class, but basically just saying that there is tension lines and patterns of tightness throughout the body. Basically, if you look like on your forearm, that skin probably doesn't move too much, whereas you start looking into the joints and the fingers, like face, you're going to see a lot more dynamic tension. So that's pretty pertinent to us as far as when you guys are considering like people that have lacerations, do they need to go to the hospital and receive stitches? Well, sometimes that is determined where is that laceration? Is it in a spot that isn't going to be able to heal because it's kind of in a dynamic tension spot of the skin where it's going to constantly be aggravated? So sometimes determining if they need stitches could, potentially be that, or staples or glue or things like that. So
I never thought about that. Right after reading this, some lady cut her skin tension area.
Skin tension area, yeah, right. So yeah, if you have a laceration on the knee, that skin's going to be, unless they can splint it and stay off of it, it probably should get stitches or something to hold it together. So closed injuries, usually described by a contusion or bruise, injury that causes bleeding beneath the skin but does not break the skin. A lot of times these are minor, but don't, if it's in the abdominal area, a lot higher level of concern, right? So your abdominal cavity can hold a lot more blood. So let's talk about blood underneath the skin. What are some terms for blood underneath the skin? Ecchymosis. What's ecchymosis, Ryan? Just a bruise. Is that a medical? So it's just kind of under the layers of the skin, right? Kind of in that tissue. Whereas if you have blood pooling in a compartment underneath the skin, what do you call that? Hematoma. So good one to know, difference between ecchymosis and a hematoma. Again, like a knot on the head, hematomas. You can have it where not very severe to where they're, again, pooling in somewhere like the thigh. That blood compartment's huge, and although it is still classified as a hematoma because it's in that compartment, but the severity is extreme in that case. Oh, and right into it. Ecchymosis and hematoma. Crushing injury occurs when substantial force is applied. So we talked about compartment syndrome, and then you also have crush syndrome. So tissue necrosis develops and results in a release of harmful products into the bloodstream when the limb is freed from entrapment. So remember there is a difference between crush syndrome and compartment syndrome. So, but the what's getting released is the same. So. Yeah, so it is more acidic, right? Because I'm not sure when you walked in, Warren, but yeah, we talked about, and we'll throw it right back to these guys. So after about 2 to 4 hours in in a crush injury, what's being released? Lactic acid, right? Which changes your pH and does cause more acidic. Okay, and then as those cells are breaking down, they go from what metabolism to what? Anaerobic, or I'm sorry, aerobic to what? Anaerobic. And then what's going on with that cell? The cells being affected. Yep.
So does that have to do with like the trauma triad of acidosis, like the trauma triad? How it talks about like acidosis, is that the same sort of thing that's happening?
Well, right, they are so there is an acidosis on the metallic level of things that's happening, and that's because of the release of all these products.
During a traumatic event, that's what I'm saying, like when things are destroyed like that, is it the same thing we're just talking about is happening?
Yeah, yes. I think I'm not familiar in the way you would put it as far as that goes, but it is acidotic.
Secondary to trauma, like acidosis is something that can kill you.
Oh, absolutely. Yep. Because of we talked about, it's not necessarily blood loss, although that compartment, depending where it is, can cause you to become hypovolemic, but because of the acidotic state, because electrolytes are anions and ions, so they are changing your pH. So we have all that. What was that electrolyte being released from the cells? Electrolyte. So you guys remember it? Potassium? Yeah, potassium. So too much of that potassium affects your sodium potassium pump, right? So at the cardiac level, so can cause dysrhythmia. So that person could die. Do you know at the ALS level what we can provide to try to help stabilize that? Bicarb, right? And or probably sodium chloride, but sodium bicarb is our go-to.
So say big pillar building collapse, something happens, comes down, say it has an issue with a solid organ, right? Like the spleen or the liver.
Okay.
And you get some sort of crush syndrome going on. Theoretically, like if you had lacerated one of those organs or caused them to rupture and you still had that pressure on there, would you not be bleeding out yet? Kind of like direct pressure, and so it's just a real, you want to have a line established before you relieve that pressure because you're going to become hypovolemic, or would that just continue to bleed or back up somewhere else? Or
Okay. Yeah, so the question is, say you had some kind of mechanism, in this instance, a pillar fall down on someone, crush the abdomen, and maybe cause injury to one of your solid organs like your liver. You said pancreas? Okay, I was going to say I don't think pancreas is solid. So spleen. Um, so I think, and I think you're kind of looking at a whole nother mechanism as far as as far as being a compartment syndrome. I don't necessarily think you're still having a crush syndrome where tissues are damaged and are releasing those. But yeah, you are looking at maybe more of a possibly a hypovolemic state of how much the abdominal cavity can hold. But as far as holding pressure on that abdominal cavity, I do agree you do need fluids in that instance for the hypovolemic side of things. But as far as why we give fluids prior to the release of a object for compartment syndrome is kind of or for crush syndrome is a different mechanism. So if you guys can imagine, so say I fill this water bottle up with, let's just say 200 mLs of water, okay? And I put a tablespoon of salt in there, okay? What's salt? What's that? Sodium, okay? So you could probably see that salt, right, with 200 milliliters. Okay, so think about that in your body when all that potassium is being released. If we can fill up this container with more water, what's happening? We're diluting it, right? So not only are we, when we release that mechanism that is holding whatever appendage or wherever we're at, not only are we fixing or not fixing, but we're trying to correct hypovolemia for a short period of time, we're also helping with the dilution of that potassium as well. Does that make sense?
Yep.
Okay.
How like fast is this gonna happen? Like if you go on someone who's got their legs pinned between two cars or something, like
Yeah.
you're gonna release them and like immediately they're gonna decompensate.
So yeah, the question is, how fast is this going to happen if someone had maybe both thighs pinned from a vehicle, whether struck or maybe they're a mechanic working underneath? Is it going to happen extremely fast? As far as literature goes, there is no specific time. You can release that, and besides all these, the potassium release, the lactic acid, the myoglobin, what else do we have to look out for? Bleeding, and what else? Think about that area has been stagnant for a while, and when the body's trying to heal itself, there's a clotting factor, right? So you could release that, and maybe this stuff doesn't get you, but maybe the clot in the system will get you as well. So, but no, typically they say 4 to 6 hours as far as for those cells to break down. When you release it, are they going to die right away? Well, yeah, that can happen, but it can also take some time. So we'll get into a little bit more of the treatment later on, but we've already talked about, early fluids. So back to injuries. So open injuries, that picture right there, what's that a picture of? Abrasion. So are they dangerous? Not particularly. Yeah. So they can be, right? So not typically a big deal acutely, but chronically, right? What type of patients do we see infections in? Sorry, that's all right. Yep, go ahead. So
we see those big abrasions on people who like motorcycle, like especially in the summertime, the guy in the t-shirt and shorts on the motorcycle.
Yeah, road rash, abrasions for sure. What kind of patients are prone to infections? Young and old, yeah. What about disease processes? What type of diseases out there that you tend to see more infections with? immune deficiencies, and then poor circulation, right? What's the common ones out there? Diabetics, right? And they, what type of diseases are out there that are bacteria resistant? MRSA, staph, right? And then all of a sudden you take this abrasion and now you might be getting into like necrotizing fasciitis, right? So a friend of mine, a lab tech, talked about this guy that started off with just a simple wound on the leg, but it kept becoming infected, staph, necrotizing fasciitis. He'd go to the hospital for a few weeks, be fixed, antibiotics, told to change its dressings, but come back and it's infected again. Well, this happened over like a course of a year and a half. And we see these patients, right? We've seen those gross necrotizing fasciitis wounds at the hospital, and sometimes we see them multiple times throughout years. Well, this patient ended up dying because the infection became so bad and got into the bloodstream. Patient died. So they did an autopsy, studied the wound, ended up finding the same strains of saliva to a canine. So this patient, for over the last year, would go home. Oh, it looks like the battery's dying on this mic. We'll get it changed on this on a break coming up. Okay, thanks, Rusty. So this patient was going home every time after being healed and then letting his dog lick his wound. So there's and I remember it as a kid growing up, that people thought like, oh, if your dog's mouth is supposed to be clean and you're supposed to let him lick your wounds. Well, his dog killed him. And then I also think about how many faces that dog probably licked in between that time. But so it's pretty gross. So. So abrasions caused by friction when a body part rubs or scrapes across a rough, hard surface. Lacerations, there's a good picture there. Smooth or jagged cut caused by a sharp object or a blunt force that tears the tissue. Let's go ahead. Let's take about a 5 to 8 minute break. We're going to come back. We're going to finish up these categories of injuries, and then we'll probably watch a quick video on burns, okay? So take a break.
Oh no. Oh shoot.
Nobody knows what to say.
Yes.
Stare at each other. Chill for a second.
All right.
Quick.
All right. So, getting back to it. All right, open injuries, avulsions, injuries that separates various layers of the soft tissue so that they become either completely detached or hang as a flap. What's some common areas for avulsions?
Hands, scalp.
Yeah, hand, scalp, fingers, getting degloved, descalped. Amputation, completely avulged, body part. So consider all animal bites as contaminated and potentially infected wounds. May require antibiotics, tetanus, prophylaxis, and suturing. So, yeah, anytime, any kind of bite, just plan on infection. You guys see it out in the field. Always recommend for your patients to get in. Probably get on a prophylaxis antibiotic. So. Human bite that has penetrated the skin is a serious injury. So, open injuries, penetrating wound, injuries resulting from a sharp pointed object. All right. So what's that coming out of that guy's abdominal cavity? Yeah, organs. Yeah, pretty. Yeah. So it looks like what's in that lower right quadrant? Yeah, large intestines. What do you think that's coming out of the upper left? So definitely a good thing to know, not only for practical use out in the field and diagnosing abdominal pains and injuries, but as well as for your test. Know what organs are in your quadrant. So what organs in your upper left quadrant? So you do have spleen, kind of a little bit lower, pancreas. What's the big organ right there in that upper left? Anyone at home can have a good guess? Educated guess? Sometimes you guys might see access ports in those areas on patients. Yeah, stomach, right? So J tubes, G tubes, just depending where they access the stomach or the small intestines. J tube for jejunum or G tube for just gastric tube. So. More open wound, crushing injuries may involve damaged internal organs or broken bones. Blast injuries may often result in multiple penetrating injuries. You guys remember for like blast injuries, your type of force there's like categories and so primary, secondary, tertiary. So what's your primary? So yeah, your initial force, right?
Like the shock wave from the blast.
Yep. Initial shock wave of the blast. So then what would secondary be? Body hitting an object. Things kind of rattling around too, interior, right? Or is that part of?
I think that's tertiary.
Is tertiary that, or is that part, or is tertiary when secondary objects fly? Okay. Well, let's look it up on next break. Get a clear answer. I wish I still had that committed to memory, but I don't. And you guys might have or will cover specifically blast, or you guys already covered it. So, yeah, that's I almost guarantee you the term for each one of those will be on your test. Not necessarily each one, but some category of those will be on your test. I remember it when I went through it. So page 1078. So if you're following at home, you can just look it up. So your primary blast is injuries due to the blast wave itself. Your secondary injuries due to missiles being propelled by the blast of the force, and your tertiary blast injuries due to the impact with another object.
So your shrapnel would really be your secondary.
And then your body falling and like hitting the ground is your tertiary.
Yeah, so your body falling and hitting the ground is tertiary. Though it looks like they added a couple more to that. When I remember it, I just remembered the three, but quaternary. Yeah, now you got 5. All right. Those books just keep getting thicker and thicker. All right, so pathophys of wound healing. Talking about infections, streptococcus, Staphylococcus, so basically staph infection, account for most bacterial skin infections. Shows visible clues. Not only can you start seeing an infection. Well, let's talk about sight. What are you going to see with infection wounds? Yeah, redness, heat, swelling. And then, is there any other sensory that might? Body temperature. What about us as a provider? When we walk in a room, we see, we smell too, right? Yeah, they can have a really bad odor. Gangrene, dead tissue, caused when blood supply to that tissue is interrupted or stopped, can be caused by other diseases, and we already talked about it. What are those diseases? Diabetics are huge. Yeah, and then just of course autoimmune and people that already know that they're like bacteria resistant, can become necrotic and result in sepsis. So tetanus is rare but very severe, caused by Clostridium tetani. It's an anaerobic bacterium, meaning it doesn't need oxygen. Causes the body to produce a potent toxin, which results in painful muscle contractions that are strong enough to fracture bones. What's a common muscle contraction in the body with tetani? The jaw, right? Which is called what? Lockjaw. What's another word? I always think of like Christmas, but it's trismus. Yeah, trismus is just lockjaw. So pretty crazy. I've never, I take that back. I think I've been on one person with a history of tetanus before. And I think that was someone out of Nyack. I think they even lost their ability I think they ended up paralyzing them, but somehow. But yeah, it's sounds like one of the worst things that could ever happen to somebody. So what can we prevent tetanus? Yeah, immunization. How often do you have to get immunized? Yep. Yeah, every 10 years, maybe with a booster. Seems like if there's any question and doubt, they'll just give you another tetanus shot. Necrotizing fasciitis. So that's describing the symptom, right? It's a inflammation of the fascia. So most serious of this condition is called necrotizing fasciitis. Involves the death of the tissue from bacterial infection. So let's go back, watch a little bit of a video real quick on the burn. This is kind of where I feel like we're kind of getting into the PowerPoint that's kind of redundant and or I know kind of information that I know you guys already know. It's just kind of mundane. So we'll kind of speed it up now that we kind of got through the meat and potatoes. So.
Burns are skin injuries caused by chemicals, electricity, or radiation. Your doctor will recommend treatment based on the size of your burn and the layers of skin the burn affects. Your skin has three main layers: the epidermis, the dermis, and the hypodermis, or subcutaneous layer, containing fat, blood vessels, and nerves. Beneath the skin are tissues such as muscle, fascia, and bone. First degree or superficial burns affect only your epidermis. The burn site appears red and dry with no blisters and is mildly painful. Second degree or partial thickness burns involve your epidermis and portions of your upper dermis and lower dermis. The burn site is red and moist and may be blistered, swollen, and very painful. Third degree or full thickness burns extend through your dermis and into the hypodermis. The burn site appears patchy in color, ranging from white to brown, with a dry, leathery texture. Because the burn is so deep, it causes little or no pain. Fourth degree burns involve the destruction of all layers of your skin, sometimes extending into the underlying muscle or bone. These burns are brown, dry, charred, and almost always painless. You can treat your first-degree burn by soaking it in cool water for a few minutes. To soothe and protect the tissue, apply an antibiotic ointment and cover with a clean, dry bandage. You can take acetaminophen or ibuprofen for pain. Care for a second-degree burn by soaking in cool water for several minutes. Apply an antibiotic ointment to prevent infection and cover with a clean, dry, non-stick bandage. Change your bandage every day and make sure your hands are clean. Acetaminophen or ibuprofen may help with pain and swelling. If you have a third or fourth degree burn, go immediately to an emergency department. If you can, elevate the burned body part higher than your heart. You will also need to seek medical attention if your burn is larger than 3 inches in diameter, or if it is located on your face, hands, feet, groin, buttocks, or over a major joint.
In your book, you guys should have the mnemonic X, A, B, C, D, E.
Good grammar and spelling are important, but if you
One of you pull that up.
Pull it up.
Yes.
What do you need now?
Messages that forge a brighter.
What that is.
X.
Oh, well, hold on one second. Just ready? All right. So we're just going to be finishing up on the assessment and treatment. So we're kind of getting to the end of this. So as we start coming to the end, if we didn't answer anything that you guys were looking for, definitely bring it up. So assessments. Yeah, so it says dress appropriately, maintain a high index of suspicion for internal injuries. So rapidly determine whether threats to life are present using this mnemonic. This mnemonic I don't remember being around a few years ago. So what is it, Warren? Or who? Yeah. Extenuating hemorrhage, airway, breathing, circulation, disability, and exposure. So yeah, if that mnemonic works for you, I'd say at least put it to memory in case they have it for you as a test question. So so a lot of kind of just obvious stuff that you guys already know from the basic level and you guys' current experience, but control any visible substantial bleeding using appropriate methods. What are appropriate methods for maintaining bleeding out in the field? Yeah, so let's talk about extremity. So let's say if I have a laceration and I'm bleeding on the forearm, what do we start with? Pressure. Okay. What else? Bandage, elevate. Okay. They're not really teaching pressure points anymore, right? Okay. What is something that law enforcement you might typically do? Tourniquets, right? I've seen, it's crazy, like lots of officers talk about they've applied multiple tourniquets in their career. I think 12 years of being in this field, I've done it once. So, I mean, I've usually the body has a great mechanism that if you can hold and apply pressure, arterioles will constrict and stop bleeding themselves with enough pressure. So, if you do apply a tourniquet, what are we doing? Time, place. Yeah. So you can mark it right on the appendage, right? What time you applied it. So how tight do you make it? Yeah, just until the bleeding stops. So as you're starting to, depending on the tourniquet, a lot of them now, you're just turning, and once you see the bleeding stop, you can apply it. Tourniquets are, this day and age, they're kind of more pro, and as years have gone on, they've said they've kind of been against it. They've been against taking them off, but now they're having really good results. I believe all the way up to like 4 hours now of applied tourniquets. So they're definitely something to look at using if needed. Talking about arterioles, I don't think it hits it here in these slides, but it is something that you guys need to know for the test as far as the basic anatomy when we're talking about arterioles. But what are the layers of an arteriole starting from the inside out? Everyone's looking away. You guys, it's kind of there, right? It's fuzzy, but you guys kind of remember. But arterioles is kind of a big one for you guys as advanced when, as far as you guys are doing vascular access. So definitely probably going to see the anatomy of it on your test. So it's like tunica intima, right? So what layer is your tunica intima? Just like it sounds, intima. It's your innermost layer of your vessel. So as you can imagine, it's gonna be thin. It allows free flow, promotes exchange of nutrients and waste products. Okay, so if the innermost layer is your tunica intima, what do you think? Something sounding for your middle. There's 3 layers. So there's the intima. So what do you think your next layer is called? Media, right? Tunica, media. You're exactly right. So if you guys just kind of use common sense, you guys can nail that on your test. What do you think the functions of your media is? What's that? exactly. And if you have expansion, you'll also have constriction, right? So dilation and constriction, that all happens. Media, kind of your meat and bones of it. That's where the muscle is. That's in the vasculature that's causing the constriction and dilation. Which, now your last layer, so what do you think your last layer would be called? Probably like what, tunica? Yeah, it was kind of a trick question. They totally went away from common sense. So it's adventatia. So just remember, if tunica, and I'm probably butchering, but adventatia. So that is your outermost layer. As it makes sense, though, when you guys think that it has connective tissue. So that way, some people's veins do roll. So you probably not as much connective tissue there, but connective tissue, and then provides protection to the inner part. So what's the innermost layer called? Tunica intima. In the middle, tunica media, and last, and adventitia. So I remember one, in some sense, of that anatomy was on my test. I do remember that. So all right, back to the survey. We're going to take care of bleeding. We talked about if we have a cut on the arm. What if we have like a puncture wound in the abdomen? How do we take care of that? Sterile dressing. What kind of bandages do we have to cover that? What's that? Occlusive, right? What if it's in the chest? Yeah, same thing. What do we have to worry about when we do bandage that in the chest? Sucking chest wounds. So, potentially 3 sides or burping, looking for, what are we looking for? Yeah, what's that called? Yeah, pneumothorax. Yeah. So, yep. Church is right. Occlusive. What about in the neck? So again, more like a puncture wound. What do you think? Yeah. So occlusive again is a good one. Obviously if you have to control bleeding, then control bleeding. But occlusive dressings, I kind of think from neck to abdominal cavity. So during your primary survey, we got to be careful of distracting injuries, right? They truly are distracting, but still got to think about your head, neck, and back. Got to be thinking about other injuries that you can't see, if blood's pooling in compartments that just aren't showing. Head injuries, how did the injury happen, right? Was it mechanical based or medical based, So that means getting a good history, right? Getting a pertinent medical history of how did the injury happen. What's OPQRST? That mnemonic was around for a while. Onset, provocation, quality, rate, severity, and time. So higher priority should be given to patients taking warfarin or other anticoagulants. What's warfarin also called? Coumadin. Rat poison. What? Yep. Rat poison's warfarin. All right. Secondary assessment. Again, when you're doing a secondary assessment, you also have to think about what treatment did you apply. So if it was like that chest, by your treatment, did you cause a pneumo? Did your splinting of that extremity extremity, all of a sudden cause you to lose distal pulses. So checking CMS, things of that nature. Is your patient becoming hypovolemic, because now the blood is, whether it's exterior or internal bleeding. So, yep. So let's talk about monitoring devices, quantify patients' oxygenation, circulatory status. So let's say someone with we'll do a real patient. So I had a patient that fell on a scooter last summer or the summer before last, ripped open up her thigh, and there's tons of bleeding on scene, and we're getting oxygen sats, I think, of like 57%. She was conscious but disoriented. Wasn't able to. She was confused. So that oxygen percentage, she was hypotensive. Is that a real oxygen sat? No. Yeah, body's shunting blood. Okay. Extremities, extremely cold. Okay. Did we put oxygen on her? Yeah. Was her oxygenation the issue? No. She was still breathing. She was breathing just fine. Even though we put some oxygen on her, that oxygen wasn't necessarily doing anything for her because she was still bringing on oxygen herself just fine. But it was more of the hypovolemia and the body's reaction to shock to shunt blood to the core. So always just take that in consideration when you're looking at oxygen sats. Is it a true reading? So reassessment of the patient's condition should be made en route to the hospital. Reassess the airway, breathing, and circulation. Describe the mechanism of injury, the position in which you found the patient, when you arrived on scene, and an estimate of the amount of blood lost. Extremely hard to estimate the amount of blood lost, but do your best. Provide an accurate account of the treatment. So position of the patient at the mechanism of injury can be a big deal. You find a patient sitting up, maybe in a vehicle, and maybe they're unconscious, but as soon as you lay them down in a supine position, maybe their GCS starts improving and they become conscious a little bit more. What is that telling you? Yeah, hypovolemia or compartment, could be hypovolemia secondary to compartment syndrome. So just really looking at a full head to toe assessment and see what's going on. Closed injuries. Extensive closed injuries could result in hypovolemic shock and can be life-threatening. Treat a closed soft tissue injury using the RICE's acronym. Looks like they've added an S. So starting with R, what's R? Rest. I is what? Ice, compression, elevation, and splint. So extremities that are painful, swollen, or deformed should be splinted. The patient shows signs of shock, place the patient in a supine position, initiate IV therapy, give high flow oxygen, and provide prompt transport to the hospital. Why are we still doing Trendelenburg position? It's not pushed anymore, right? Do we know why?
They didn't ever show signs that it did anything enough to teach, I think.
Yeah, so Ryan's saying it didn't show signs of doing anything, and that's why we're not doing it. So if you actually lay someone down, put their legs up, you actually will see increased like systolic blood pressures. But it's only for a limited amount of time. And from research, they're saying that it can have a negative effect because of what they call a rebound blood pressure. So basically your baroreceptors, you have them all over your body, above your heart, in your neck. I think in that aortic arch, you have baroreceptors, and those receptors are just monitoring your blood pressure and telling your body, hey, we're hypotensive, let's kick up our blood pressure. Well, they're getting kind of a false feedback when you raise your legs, allow that blood volume to help go to that core. Your body thinks it has more blood volume than it does, and then it lowers that blood pressure after some time. So they kind of just went away from it from that stance. The supine position is kind of a happy medium. Does that make sense?
Yeah.
So I imagine that it's been long enough time that your test should reflect that. But I don't want to set you guys off on the wrong foot, but I imagine because does your book talk about adrenaline? Okay, good. So I would feel very confident then that the National Registry is going to be the same way. So we're kind of just getting through this. We've already been through this about 4 different ways, but direct, even pressure, pressure dressings, and or splints and tourniquets for open injuries. Chemical burns and contamination should be flushed to remove remaining chemicals. After a wound is irrigated, apply a dressing over the site. Neatly wrap a bandage over the dressing. So make sure you guys take in consideration these slides. A little bit contradicts itself because you also need to know what chemical you're working with and make sure it's not water reactive. More redundancy. We talk about covering wounds, control bleeding, and limb motion. Dressing directly covers the wound and controls bleeding. Types of dressings. Yep, we all know this. 4x4s, 4x8s, all different sizes. Yep. Hemodynamic complications include the possibility of continued bleeding. Can result in additional tissue damage or even the loss of a limb. Again, we talked about a couple of those disease processes, so, and or not blood thinners on board. Again, we've already gone over avulsions, amputations. So partial amputations, immobilize that part with the bulky compression dressings and even a splint to prevent further injuries. If you guys can, by manipulation of the limb or body part, get a pulse back, then splint in place. So common sense, right? If an animal's at large, we want it secured. Dispatch these days, regardless of what the family or RP says, they just want all animals secured. So, kind of preaching to the choir here, right? But remember, we're not just an ordinary person going into someone's house. We look different. Our uniforms look different. We're usually putting contact onto a patient, which that's that pet's master. So they're not going to act in a normal behavior that even the patient may be used to. So we're also wearing gloves and stuff. So just always be on guard with that. So we talked about animal bites are nasty, and one way or another, the patient should be getting on a prophylaxis or antibiotic. So penetrating wounds, entrance wounds, and exit wounds are difficult to distinguish. You count the number of wounds. So it seems like in the last couple of years, we have had a lot of GSWs. Like it said, sometimes it's hard to distinguish what's entry, what's exit. Is there an exit wound for every entry wound? Again, just like we talked about electrical burns, the exit wounds are going to be way more traumatic than the entry part, right? And it also depends on the caliber of the weapon. Just a side note, with GSWs, as far as PPE goes, what is something you guys should consider? Yeah, like so respiratory protection, right? Just because the atomized blood due to gunshots. So the amount of damage from a gunshot wound is directly related to the size, shape, and speed of the bullet. The amount of damage from a gunshot wound is directly related to the size, shape, and speed of the bullet. Yeah. What's the most common caliber out there that kills people in the world? Is it any guess? Anything from 9mm, 22s to 45s to 50 calibers. I mean, there's 38s. I mean, Kaipo could probably name about 25 more calibers, but there's shotguns. So it's 22s. You know, it's a very common round, and then it's just it tends to enter the body cavities, but then just tumble around, right? So it kills more people than any other caliber. And that partially probably just because it's more frequent too. So, oh, yep, Coulter's right, 22. Abdominal wounds, we've kind of hit on it already, but internal organs are protruding through the open wound. Do not touch or move them. What do we want to do with those organs that are protruding through an abdominal cavity? Yeah, moist and sterile dressing. Okay. So it talks about if the patient's legs and knees are uninjured, flex them to relieve the pressure of the abdomen. The body, a lot of patients will just almost do that, just, you know, not even thinking about it. It's just that creates that pressure relief. We talked about impaled objects, neck wounds, how they're we're really not going to remove them unless it's impeding the airway, and then we're going to just take care of the bleeding and throw an occlusive dressing over. Talks about do manual pressure, but do not compress. You know, they frown upon wrapping like tape around the neck, or, you know, I don't really need to explain why. So, burns. So we've hit burns a lot already. We've talked about the different severity of the burns and where, at what degree. So as far as first, second, third, also called what, guys? Superficial, partial, and full thickness. Something that, as far as pathophysiology goes, remember fluid shifting from that intravascular space into the extra vascular space causes edema. So burns to like any body part, right? So forearm, biceps, chest. I mean, chest is a big one, but all that skin, because the fluid is going to leave those cells, it's going to get tight, right? Those sebaceous glands are going to be burnt through on those second degrees. So the skin is going to get tighter, and sometimes they need to get in and they actually have to put incisions into that area to reduce that swelling. That thoracotomy or thoraectomy, but yeah, they have to cut the chest, otherwise the compression is on the respiratory muscles, and they're basically going to suffocate. Hypovolemia causes a decrease in cardiac output, resulting in hypotension. As the burn destroys the skin, a tough leathery substance known as eschar is produced. May require a escharotomy. There we go. And then just depending on location, they might hear it as well. We're almost done, guys. So would you guys rather just keep blowing through these last few slides and we'll get you guys out of here? Okay. So you guys are familiar with hypovolemic shock. It occurs between two types of injuries, fluid loss and a series of volume shifts within the rest of the body. Depending on the nature of the burn, the coagulation disorders may cause the patient's blood to clot more easily, resulting in an emboli, or fail to clot, causing excessive bleeding. So Another thing to think about, again, is those embolies in burn patients. High risk of infection, hypovolemia, shock, airway obstruction, breathing, compartment syndrome. So I did have a chance down in Lubbock, Texas, to go into the burn unit for clinicals. It's a crazy experience. If you guys ever get that experience, take full advantage. But they have these burn patients. They have to clean the wounds multiple times a day. And these rooms, depending on how severe that burn is, they crank up the heat in these rooms, and they're extremely hot. And you go in there and you're just sweating, and then they have to brush away on the wound on the burn site, and it looks absolutely painful. Regardless of the medication they give these patients, but it is very severe, but very interesting. So the progression of burn wounds, it talks about coagulation. Zone of coagulation is the central area of the skin suffers the most damage, and then zone of stasis, the peripheral area surrounding the zone of coagulation, and then the zone of hyperemia, area least affected by the thermal injury. I would imagine that's probably 3 good terms. Anytime you guys see terms in your books or on PowerPoints, it's usually easy way for them to form questions out of. So just knowing terms. So, yep, we've already been through all this. We're just moving on. Good picture. Sunburn is what degree? Blisters is a key sign of what? Partial. And last but not least, your blackened is what? Full thickness. So burns seem to be a hot topic for your test questions, and so we're going to be getting into the treatment rules of 9. So for an adult patient, what's your head? 9. What's your chest? What's your back? What's your legs? 9s, right? So when you're trying to figure out your burn percentage, you count those up. What's your perineum? 1, right? So you're one way or another, you're going to get a question like this on your test. So which goes right into what's the treatment called as far as the fluid volume you need to give your patient. What do they call that? It's a formula. Parkland, your Parkland burn formula. Is that not in your books? I know you guys all stayed up reading your chapter last night, and you guys are probably just fried a little bit, but so quick scan through your book. I'm not seeing it, but you guys almost guarantee that it is expected out of you from the National Registry. So when dealing, especially as an advanced, you guys, this is right down your alley. So
they do have it. They've renamed it as the consensus formula.
Oh, so they've renamed it to the consensus formula. So it talks about how much fluid you need to administer within the first 24 hours after the injury is typically given. So I'm going to go ahead and you can fact check me, but I imagine they haven't changed the formula, but the Parkland burn formula. So you need to figure out the percentage that actually was burned by that, was burned on the patient. So, and then it's, you take your kilograms of that patient. So how do we figure out kilograms? So is it 2.2 pounds equal 1 kilogram? or yeah. So if you have a 200-pound patient, what is that? 90. Okay. So I did just last week help with some stations for the National Registry for some students, and out about 12, 2 failed on the fluid resuscitation of a patient, just because they were told to give a fluid bolus of what's the typical fluid bolus for weight based? What's the typical? 20 what? 20 milliliters per kilogram. Okay, so they were given a patient, I think that was 90 pounds. Okay, so the pediatrics, let's say you have a pediatric that's 20 pounds. How much do they weigh in kilograms? About 9 kilograms. Okay, so how much fluid bolus are you going to give if you're ordered to give a 20 ml per kilogram? 180. Okay. You will have an IV station, and you'll have probably a neonatal IO station. It's not just being able to do the skill, but in order to get through that station, you have to be ready to know how to properly fluid bolus that patient. So same thing with the Parkland burn formula. You have to be able to, in a scenario-based question, be able to take that patient's weight, go to kilograms, and then apply the formula. So it should be 4 times the patient's surface to area that's burned, and then their weight, and then you're going to take that and provide half that fluid bolus within the first 8 hours. Can you read what the formula in your book?
Yeah. So our book says 2 to 4 mils times patient's weight in kilos times percentage of body surface area burned is the total fluid in 24 hours.
Yeah, so in your book it says that's the total amount you're going to give in 24 hours. So you want to give half of that in the first 8, and then the second half in that last 12.
So,
Or I'm sorry, in the last 14.
so if we were to get a burn patient,
16. Public math is bad. So 8 and then 6 and then the last 16 hours. I'm sorry, what's
if
that?
you were to get a burn patient, you're going to figure out that formula, and then you're going to give them fluid, but like keeping in mind that you can only give them so much. Like, is it supposed to be evenly spaced out over 24 hours?
Our treatment, though, it's a lot of fluid to get in the transport.
It is, right? Yeah, so let's, right. So, but we do need to start heavy fluid boluses, and we need to keep track. That way, when they do get to the whatever hospital they're going to, they know how much. Okay, and let's just throw out a formula so you guys
2 to
can do it.
4 is a big difference. Once you
Yeah.
multiply it by another 2 numbers.
And
They give an example, and with 2 it's 6, 7, 5, and then it's
Yeah.
13.
the way I remembered it is 4, and instead of trying to remember ranges, I usually will just pick the range, and for when I learned it, it wasn't a range, it was 4. So if you guys can remember 2 to 4, or if you just want to remember 4, I remember 4. So let's go easy. Let's say that you have a 220-pound patient. So let's figure out this Parkland burn formula step by step. So you're going to start with what? I'm sorry. Let's talk about they're burned on the front part of the chest and their face. Okay. So 27%. How did we get that? 9 and 18. Okay. So now we're doing what?
27 times 100.
Where did we get 100? 100 what? Well, always kilograms, right? So 100 kilograms times 27 times what? Times 4. What do we get? 10,800. So that's almost 11 what? 11 liters. So now what do we need to do? As far as if the question says how much does that patient need in the first 8 hours? Divide by 3.
The first 8 hours
divide by
Six bag. I mean, it's half, right?
What is it?
We're looking for a third. Oh, I said the first thing, how do you get half?
So,
Yeah, or you could just figure out what you need to give per hour and then times it by 8, right? So if you have 24 hours, you can just divide by 24, and then you know how much you need to give per hour, right? And then you can times it by 8. That everyone does math differently in their head. That's the way I think. But
They kind of like all of us have less than an hour long transport.
Yep.
Probably not gonna, no matter
Yeah.
how much we give them, it's not gonna
So
be an hour.
how much are we giving this patient in the first 8 hours?
the first 8 were
Yeah.
About
it's a little less than
liters.
So about 4 liters. Yeah, 3 1/4. So we can at least start probably 2 large bore IVs if we can, and just start fluid bolusing. Yeah. So
At what point do we run the risk of, I guess, over diluting?
yeah.
I mean, that certainly would be a real possibility. Right? I don't, maybe not in our transport, but it seems like we can kind of count on that.
Yeah. So Warren's question is, at what point do we have to worry about over diluting? So I'd say you start, well, so remember, this isn't a normal patient. This patient's fluid volume is shifting out of that vascular space. So that's why they are able to take on a lot more fluid. So we still go back to our vitals, right? Lung sounds, blood pressures. At the hospital, they're obviously able to do labs and have a little bit more tools at their exposure to, yeah. So any questions on the burn formula for you guys out there at home, or anyone here in class, or you guys feel like if you guys get questions on it, you'll be able to work through it? I would put that on a note card or somewhere where when you guys go back to review prior to your test, they love hitting burns and then treatments of burns. So here's that graph as far as peds, child, and then adult. So on the childs and peds, you're looking at 8. You're looking at, obviously the heads are a lot more than the adult, just because of obvious body surface area.
The book notes that on the Parkland formula, it was originally 4 mils, and then the consensus formula came out because in the hospital they based off urine output in the blood labs, and it's more often 2 mils.
Okay, so
Sounds like EMS 4 mils would be appropriate.
okay, yeah. So Max was just bringing up in his book that they did go from that Parkland burn formula and renamed it that consensus burn formula, because they did find in the hospital that 4 milliliters at times were too much, just due to the urine output and lab values. So they found that 2 mLs did seem to be more appropriate. I would imagine too, for initial acute injury, that higher fluid bolus is all right, and then as they get those values in the hospital, they can titrate to effect. So assessment of burns, again, kind of state a lot of the obvious, but you want to do your best to classify that burn, determine its severity, continue to check up on that burn, because when someone gets burned, the burning process isn't over as soon as they're away from that, whatever caused that burn. So doing everything you can to stop the burning process and then continue to reevaluate, because maybe obviously the first degree moved to a second, or second to third. So. We all know primary surveys. You guys beat that to death on almost every class you guys do. We're moving on. Yep, history taking. You guys know this is all. If you guys don't know this stuff by now, then let's just say let's not. Yeah. Yep. secondary assessments. Yep, I'm only thing out of this that is the suits around the mouth and nose and singed nasal hairs can mean what to you guys? Yeah, inhalation burns, definitely, whether it's getting ALS en route or be thinking about how far you're out, that should you be getting life flight or any air ambulance en route.
I mean, I guess how rapid would you be dropping an ideal? Maybe you're not seeing it right now, but you know it possibly could be.
So yeah. So yeah, Warren's asking about the eye gel and how, I guess, what proactive you should be about it is, I guess, what you're asking. So yeah, I would say from a ALS standpoint, when we're putting advanced airways in, we're kind of having that thought of we might only get one attempt at this. Those eye gels aren't as abrasive to the airway because it's kind of going around the glottic opening, but any kind of irritation to that tissue that's already irritated, kind of like anaphylaxis, I mean, we have to consider it. Definitely from the ALS standpoint, we're considering it a lot more earlier because we have those RSI medications where we can preemptively get ahead of the game, where you guys are kind of behind the game if they're going unconscious due to the loss of airway, due to the swelling of the airway. So you guys at that point in time are, of course, just, I'd say, go ahead, drop the eye gel and make the best of the bad situation that you guys are in. So ALS all the way, get them there, because if we can't get, an airway dropped, we can start considering surgical airway. So breath sounds with the stethoscope, that can give you guys a heads up earlier on as far as wheezes and the trauma of going on in the airway. So. Yep, we're everything from quantifying the oxygenation and circulatory status. A lot of this is just redundant, so we're just moving on. We're gonna pretty much just be pretty much finished here, guys. I don't see this any beneficial to you. You guys already know about assessments, secondary assessments. So we talked about stopping the burning assessment and then assess and treat the breathing, support circulation, provide rapid transport. Yep, we had talked about aggressive fluid resuscitation, and then administration, IV fluids. Yep. If any of you guys want to take the time to go back through these, I think we've already hit this like 10 times over, so I'm getting through this stuff with you. Yep, inhalation. We talked about infections. Carbon monoxide intoxication can cause permanent damage to organs. Be suspicious of, honestly, I don't understand why this isn't soft tissue injuries, but hydrogen cyanide poisoning. Yep, what involves central nervous system, respiratory, cardiovascular. So chemical burns in the eyes. Eyes particularly vulnerable to chemical burns. A lot of times figure out what chemical, and then if you more than likely probably irrigation. So chemical of the burn, pH, length of time, and volume is all pertinent information that you guys need to get. Yep, talked about removing the chemical from the patient, whether it's a dry or wet decon. Sodium metals cover with oil. Hydrofluoric acid, calcium gluconate gel is the preferred treatment. We do go on a lot of hydrocarbon, like people get gas in the eyes or swallow it, just soapy solution in the eyes. I'm sorry, I apologize. Soap solution. I guess people can get just a little bit of irritation on the skin from a hydrocarbon, and they're talking about a soap solution there. Otherwise, irrigation if it's in the eyes. If it's ingestion, I think it's pretty minor unless it was like a intentional. Then it's probably worth going to the hospital and let them deal with it there. But I think we've all tried to siphon gas before and getting a little bit in our GI tracts, so probably just take some Tums. So if you guys can kind of see with this treatment, it looks like they're using a saline lock to just help flush out the eye. I think it's another great consideration. So, talked about electrical burns. You guys can see in that picture of the devastation of what it could cause. As you can see, the exit wound can be pretty severe. So electricity is going through your body, so a lot of consideration of what you can't see. Through their organs, through the heart, dysrhythmias in the heart, to just injury to organs and tissues. So definitely need to be evaluated further. So radiation burns. Have you guys already talked a little bit about radiation? Okay. It definitely shouldn't be brand new to you, but just a refamiliarization. You do have your alpha, beta, and gamma. Can you pull those up?
Radiation.
Yeah. So what can you use to shield yourself from alpha? Yeah, usually skin. That. Yeah, as long as you don't ingest it. Beta. Yeah, and I'll be honest with you. Okay, so in your it just says the three types in your book, but I believe beta is just basically any kind of barrier like clothing and things like that. I apologize if I'm wrong. I would follow back up on that. But whereas gamma is what? Lead. Yeah. So. So radiation sickness can cause premature aging or even death. Require special rescue techniques beyond the initial training of advanced EMTs. If not properly trained, maintain a safe distance and wait for the hazmat team to decon the patient before initiating care. In the local area, don't be afraid to, if you have anyone that has any possible exposure to radiation, before you go to the hospital, either let the hospital know of the possible contamination and or contact KCFR Station 4. And I know I have personally in the past with patients that had suspected radiation poisoning. We've gone there before the hospital and they've gotten their Geiger counters out and checked the patient for radiation poisoning before we just took them into the ER and exposed the whole ED. So that's it, guys. So sorry, I know the last few slides of that, or the kind of last part of that PowerPoint's really redundant. I kind of just went through it. I think you guys know all that stuff. So I apologize if you really wanted to sit, kind of take your time through that. You guys are welcome to go back on that if you'd like. Other than that, that's soft tissue injuries. I hope the class is going well for you guys. If you have any questions, let me know. I'm always available to help you guys. So, all right. Hey, good luck, everyone. Have a good one.